Uh, so when I had started my FECO journey, I was like exposed to both the peristaltic and the Venturi machines. And I was bought over with the speed of the Venturi machines. But later on, as years passed, with the new generation of peristaltic machines, I found that it's a perfect balance of speed and safety, which adds to my practice. Right now, I'm using a Centurion Vision system to perform my surgeries. So over the last 2 decades, there have been major conceptual shifts which have been highlighted now and again in the previous talks, like we have from longitudinal to torsional, we have power modulation from waveform to hyperpulse, we have the anti-surge algorithms, we have the high high vacuum flow restrictive tubings, we have the dual linear pedals, we have the we have the progressive reduction in incision size. However, the end result has been basically a shift from power-driven surgery to a fluid-driven surgery. And there comes the concept of the target IOP or the active fluidics, and it concentrates on a more efficient energy delivery system so that we can perform a surgery delivering lower energy using a higher vacuum, at the same time maintaining a zero turbulence or a low turbulence. So as we said, it's a target-driven irrigation system, and there is a post-occlusion passive surge protection mechanism which limits the post-occlusion surge pressure changes to a drop of less than around 30 millimeter mercury. And if we go for the comparison of the target bottle height and the target intraoperative pressure and the bottle height, we see that while the target IOP is around 80, the bottle height is around 110. Usually people stay in the range of the 80s and 90s, so it is equivalent to a target intraoperative pressure of 60s and 70s, whereas the target IOP can go down as low as 20, which is equivalent to a bottle height of around 27, but with majority of the peristaltic machines, we can lower down to a level of around 50. So the elements of control in our hand are basically the IOP or the bottle height, whatever I'm using, the vacuum and aspiration, the irrigation factor. I'm not a scientist. I do not understand machines in general. What I understand is does it serve my purpose? Does it give me safety? Does it give me comfort? Does it ensure the safety of the patient? Does it affect the outcome? So this is something I will be more neutral to my approach when I will be handling the cases. So setting up the target IOP, we can have a standard IOP of around 55 millimeter, which can be lowered with a regular usage to around 40 to 45 millimeter mercury. And where it is important is by lowering the IOP, by lowering the intraoperative pressure, we are actually maintaining the lower pressure on the optic nerves, which can have an effect, as we know that we have a snuff out phenomenon in a moderately damaged optic nerve in glaucomatous patients. So taking care of the intraoperative pressure is probably one of the parameters, and right now intraoperative sensors in the tip are also being considered so that it gives a better sensation system, as highlighted by Bhaskar, that it is a total tubing system. The sensor is outside the eye, so it is a system. It is the pressure throughout the system. Now, similarly, this lowering of the intraoperative pressure, as you say, can be also helpful in the myopic and the vitrectomized eyes, because it can prevent a painful reverse pupillary block. And then what it transpires into, because of the pressure sensors, because of the fluid actively driven into the eye, we have less turbulence inside the anterior chamber, and we know that more the turbulence, there will be more amount of endothelial cell loss. And so we have as a result, we have a more stable relation between the lens and the iris diaphragm and a less stress on the zonules. Now, if you remember, let us take the example of our fuchs dystrophy. Fuchs dystrophy around 2006, 2007, if we have one parameter as a cutoff, as the corneal thickness, the cutoff was around 600 micron. apart from the other parameters. Though it's an absolute value, people may contradict, but that was the reported data. Then over the next decade, the thickness increased to 640. So we are able to do in a Warsaw cornea more comfortably. And probably with advent of newer machines, we can further increase our corneal thickness cutoff and give rise, and we may avert a corneal transplantation. So basically, this concept adds to our spectrum of cases, the PPCs, the Fuchs above the 640 micron cutoff, if we take it, the floppy iris syndrome, the small pupils, the ZDs, and so on. We have another important factor in this system, that is the irrigation factor, which actually compensates for the leakage. And instead of increasing the bottle height or increasing the IOP, we can change the irrigation factor in situations like where we have a shallow or a flat anterior chamber, we have the post-PI, or we have an inadvertent leaky wound, a very hard cataract, the post-R case, the corneal transplant situations. And we can also decrease it rather than decreasing the bottle height in myopic or vitrectomized eyes. So apart from it, we have a control over the vacuum and aspiration. It is linear or fixed in foot position 2, and it can be fixed in foot position 3, or it can be decreasing in foot position 3 to reduce the surge, or we can increase in foot position 3 for a better grab and reholding and repositioning. So in general, what happens is we can achieve a 20% higher vacuum with a 20% reduction of AFR and an average energy reduction of 40%. So this is reported in 2015, and this basically transpires into the safety as well as the outcome of the patient. Now, irrespective of whatever I am using, whatever machine I have, or whatever situation I am in, I want a good hold irrespective of the softness. I want to ensure followability. I do not understand machines. I want to ensure followability. I want a stable anterior chamber. I want a fast but not furious, rather safe. I want a reduced CD. I want a reduced turbulence. I want a constant pupillary size. I want predictability. So I have a host of demands when I will enter into my surgery. So we will have our first case, which is a situation of posterior polar cataract. And just like anybody, like my thought process is like when I see a banana skin, I know that I will sleep again, I will have a fall. So when I have a PPC, I know I'm going to land up in trouble. I curse people, I get angry on the retina surgeons, why they're born. But if you see, we have reduced the IOP, we have reduced the aspiration flow rate, yet we are able to maintain a higher vacuum with a stable anterior chamber. And as we start off the process, it's a softer cataract, so we just initiate a primary crab without opening the window much and take out the pieces one after the other. So when we are looking into the settings, we must understand that irrespective of whatever I keep, I may have a vacuum of 650, 700. How many times do I reach that? So all of us have a sweet spot. And it is whatever be the setting, we ultimately land up in that sweet spot irrespective of what we keep as our base and the height. So reaching that sweet spot in every case is probably the most important thing. And as we see that we could peel off the cases and we replenish the chamber with the visco. We do some visco dissection of the epinucleus and from all the sides, because this helps to this helps to probably reduce the chamber, maintain the chamber stability. And then as I peel off the epinuclear plate, I see there is a rent underneath. So this is the advantage of a lower setting, a control setting, where I am able to grab hold, I am able to aspirate, I am able to do everything without chattering, without a fluctuation of the anterior chamber. And then with the help of additional installation of visco, I can aspirate the remaining pieces as I thought that my visco content in the chamber was going down, so I needed to replenish it. So I have a rent, I have a central dehiscence, it is still under control at this point of time. And then we can go in for the bimanual cortical aspiration at the same time. And we see that we have a spindle-shaped rent within the central part. My equator is more or less clear. I can put in more visco, I can carry out some anterior vitrectomy, and ultimately, once the thing is completed, I can put a lens inside the bag. So this sort of settings helps us to reduce the size of the rent, prevent a nucleus drop, prevent a drop of the cortical matter by controlling the procedure intraoperatively. My next case is just another PPC. So the look said there is a 100% guarantee of everything happening. And this was a relatively harder cataract. The initial trench was made. I tried to separate, not very aggressive. I go ahead with the pieces. I rotate with a lot of caution, and then we go ahead with emulsification of the pieces one after the another. And then as my pieces are coming in, I'm sure nothing is there at this point of time. And then when I try to rotate, I see something. There is a clearance. I think there is a rent, but I'm not sure whether there is a rent. There should be a rent. So that piece also comes up. I cannot see anything underneath. My epinuclear plate is well in position. So I replenish with visco. And as I go for my traditional technique of putting in viscoelastic under the epinuclear plate, I find the iris is coming down out. So I am sure that there is a rent, because of the rent, the visco goes down, gives a positive pressure, and the epinuclear comes out. So in spite of that, I can continue with my process. I can control my rent size. I can take out the epinuclear plate as demanded. So I rotate the epinuclear plate and we take it out, though we know that there is a dehiscence underneath. So instead of, this is what we understand by good hold, good followability, good vacuum, and safety. So once this is over, we just put it forward. We do the cortical cleanup as we normally do, and then we put a lens in the sulcus, a multiplex lens in the sulcus, because the rent was relatively bigger. I couldn't put a lens in the bag. So the third case is again another case. I call it, why do they happen to me always? So this was another PPC.
Jangshu, do you have a small pupil or IFIS video?
I have.
Then I think we can skip to that.
Okay. Why I want to show this particular video is because this was a harder nucleus. In spite of doing the procedure, we had a intact posterior capsule, and after that, we have done everything. We have saved the capsule, but then, as I was aspirating, I found the capsule dehiscence. And this is where I observed that I had kept my bottle height at 60. So lowering the intraoperative pressure is also important, and a rent can happen anytime. I think this video is an intraoperative floppy iris syndrome. So here also, I believe I use a common setting. I do not like to change my settings. I prefer a safe setting which gives me the entire spectrum of cases. So this was, I gave the intracam and achieved the viscomydriasis. Now, traditionally in floppy iris syndrome, we are habituated to using the heavier viscoelastics like Helon and etc. But because I'm using a lower settings in such situations, I can manage the situation with a normal HPMC also. Now I perform the anterior capsular rhexis, which I prefer it anterior to the pupillary margin, so that when I'm doing the hydrodissection, the the nucleus doesn't pop out, and it will increase the chances of the iris coming out of the wound or the side port. So once it is done, I do a hydrodissection, because this is also an important aspect of fluidics, I believe, and to get the set ready before I enter into the surgery. And I see the iris is coming out from my main wound. So I do a multi-point hydrodelineation, small aliquots of fluid into the different areas of the nucleus. And then as I put my iris back, I see that I put the subincisional viscoelastic, and I see that I have achieved a decent enough hydrodelineation. So once I start off the procedure, there is a classic bellowing of the iris and the diaphragm, but that is the time I take for the stabilization of the intraoperative pressure and the pupillary size. So once my pupillary size is maintained, I can initiate the crack, and this is at a bottle height of around 60 centimeter of mercury. So there is nothing much in the surgery, only it shows that there is a minimum amount of turbulence, and we can carry out the procedure while maintaining the iris in its position. And finally, we can have a situation like this, where we can just have a proper bed for the intraocular lens implantation. After that, I think I have another video of a post-arche. This is interesting because we do get people. This is a 24 cut arche, and I did not have a position for the wound, so I was all scared about which one will open up during my surgery. And I have reduced the intraoperative pressure further to 36. My flow rates are further reduced. My vacuum, I again reach my sweet spot, and I can do a, basically I can do a phaco rolling. So this actually reduces the maneuvers inside the chamber and prevents me from opening, from an inadvertent opening up of any of the archaic cuts which I can have, and then I can flip the nucleus and just emulsify the pieces. So this is the post-arche. Then we have, I think this is a, this was a case of this was a case of advanced glaucomatous damage, where we have reduced the IOP to around 20 millimeter mercury, and we can see that in such situations also we have a very good hold, we have a very good crack, we have a stable chamber, and we can carry out the process without any issues, without any trouble. My next case is a case of gross zonular laxity, diffuse. I heard it on the table that in between, while waiting for the surgery, the patient had had a fall, like some 3 weeks back, and there was a difficulty in performing the rhexis because the zonules were weak. I thought I will carry out the procedure at 20 millimeter mercury, but when I started doing the procedure, I found that the nucleus is popping up from its position because there is no zonular support. So I just changed my settings to my, again to my 46, and I can carry out the procedure, and in the end we just put in a CTR and we could put in a lens. The last case is probably, this is probably the last case, which is a post-DLK cataract surgery, not much of a cataract in it, so I will just skip it. So to summarize, we have such special situations like glaucoma, myopia, post-vitrectomy, diabetes. It is not important what we are keeping. Machines give us the opportunity to explore. Machines give us the opportunity to understand. However, grossly speaking, reducing the intraocular pressure, reducing the bottle height, with appropriate reduction in vacuum and aspiration without compromising our individual comfort level will give rise to successful outcomes. Thank you.